Yeah, and that is a photo of our beaches, and that's our traffic in Adelaide compared with Surabaya traffic. That's our photo of our new medical school, which is just has been completed about 3 years ago. Before that, it was a very nice historical building, similar to Erlangen University, but now it's a modern building. It's nice, but it misses a bit of the history, but it's good. And it's important to make the comment that similar to Surabaya, we have a central medical school with several teaching hospitals. So we don't have one academic hospital. We have Adelaide University has 5 teaching hospitals. Because I'm doing obstetrics and gynecology, of course, a focus on obstetrics. Only 2 hospitals have a maternity service. The other 3 hospitals don't have a maternity service. And this is in contrast to, for instance, why I was trained in the Netherlands, where you always had a university with 1 academic hospital, and there are pluses and minuses in both models. I had a discussion recently when I came to Surabaya talking to Dr. Aldi, that it's also now important and complex to make sure that it stays, the people that are involved in teaching stay one team, although they may be in different sites. And happy to hear what your, first, it takes quite an effort. Adelaide is a very long stretch city. So from the other main campus, which is the Women and Children Hospital, it is about a good 40 minutes drive. It's about 30 kilometers from where I sit now. I'm in the northern suburbs of Adelaide, which are very poor, socioeconomically poor area. And it's difficult for us to keep our group of clinical academics as a cohesive team. That's actually quite a challenging something. We do all the way this is for the clinical years, of course. We do some combined teaching for the whole year on one location. And then we have a lot of teaching in the per hospital site in the different hospitals. So that is an exact complexity. Now in the new building, there is, and again, this is quite new, and I think we're probably one of the most advanced because it's new on medical simulation. So there's a lot of from very simple models like basic resuscitation to again, I'm obstetrician, of course, patients with eclamptic seizures, but also patients coming in with myocardial infarcts, etc. So they can do a lot of very fascinating simulations where, if you look at CPR, for instance, like resuscitation, they can measure the strength of your pressure, your ventilation frequency. They can even check what kind of oxygen levels you achieve in the model. So that's all quite sophisticated, and the medical students typically love the simulation. And the data in the literature are suggesting that it does help. That is clearly, it will never substitute real patients, but it is helpful. It is, of course, quite costly. The setup of this of the simulation lab was a very costly phase, and we have separate staff. This guy, for instance, who's completely trained to work with all the simulation equipment and the monitoring, etc. Oh, go too fast. So now to more the text thing. So we offer a 6-year program, but it has now been, so this is the current model, which has been just developed last year. You start with a Bachelor of Medical Studies, which is 3 years, and that has the standard things like biochemistry and things like anatomy. And then you have your 3 years of medical studies, and it leads then to the Doctor of Medicine, which is a master's level. There are now 2 research projects. One is a quite small one, and it's just for the students to know about searching the literature, perhaps baseline statistics. And then there is a, now the university is saying major, but that's still only a research topic of somewhere between 3 to 6 months. The idea is that the student at least brings it to the level of a formal presentation for a conference, and it could be a statewide conference, or ideally like a low-level publication. Most students only make it to the level of a project that can come to a conference. And I always love to supervise students myself, but I do know that that is quite a struggle for many of my colleagues that have to find time to supervise students, and these junior students still need quite a little of time for supervision. I'm of course a bit further in my career, so I think I can see retirement in a few years, so I have a bit more time to really spend on supervision of these students, but my younger colleagues do struggle to find time. So it's although we say it's an integrated program, once you're enrolled, once you have been accepted in the training, which in Australia goes on your, we get scores for your high school, for the high school results, and you need to be in the top 5% of high school students. That's a national scoring. You need to be in the top 5% to be allowed to study medicine. That is, I don't actually know what the cost structure in Indonesia. I know how it is for the residents, but not for medical students. So in Australia, then students can get a significant funding for their cost of their study and their living when they've finished their training. So it's a loan with the government. Eventually they have to pay it back, but that could be paying back over 20 years. So basically, once you're in the program, you basically, they have a spot for you for 6 years. But that is, of course, subject to that you pass the bachelor's degree. And then you're automatically allowed into the clinical years. And this is under the governance is Australian Medical Council, because they set up the minimum standards for what Australia feels a young baseline doctor. So we basically say we train you up to the level of an intern. And I'll come back to an intern, because an intern has different meanings in different lands. So we train doctors up to the level of becoming an intern. And that's in Australia very much linked to the AMC, If you come from overseas, for instance, doctor from Indonesia, a few, you have to pass the AMC exam. And basically you have to sit the same exam that our Australian students have to sit. Now, we have now our own Bachelor of Medical Science Studies, but people could also come in from, for instance, we have other university in the south of Adelaide, Flinders, and Flinders also has a Bachelor of Medical Studies. So a person could move from doing Bachelor at Flinders and come to Adelaide, or they could come from Sydney or Brisbane, and vice versa. Now, Adelaide has been very strong on problem-based learning. And my predecessor, Geoffrey Robinson, who unfortunately died not long ago, he was a very eminent scientist. And I had many, many discussions with Geoffrey over the years, and we often agreed, but we also could respectively disagree. In Geoffrey's opinion, and that's come to the core of hopefully the discussion this afternoon, in the pure problem-based learning, as most of you will be aware, the moderator, the supervisor will identify the problem, which could be a patient or a clinical question, and then the students go into the literature, find their answer, and come back with a structured answer. That is a skill that clearly needs very organized thinking, and clearly there is a group of students that is more okay with a more standardized, you could argue, passive teaching. So we went from so Geoffrey Robinson in the past would just sit with a group of students, if I'm Geoffrey now, and the students would talk with each other, and he would just say, no. He would basically have no input. The good students, they loved it because they really could show their skills and that they could show that they had been investigating the literature. The poorer students suffered. And that's clearly, and that's if I, for instance, think of Surabaya, where I just did teaching for the general year, and that was clearly different from the international year. I could just notice from the interaction and the type of questions that I got. So I think we're now probably more like a mixed model, where we still from the beginning, so that year one, even simple concepts like acid-base metabolism, then they take an example of, for instance, a sporting athlete who gets very exhausted because they're running too fast, and they go in, why is he exhausted? And they talk about oxygen and acid base. So that would be then clearly the supervisor then would be a non-clinician, like a physiologist. And they go through the whole acid base, let's say, metabolism, and they use that example of sport, for instance, as an umbrella for students to dive in. Similar things with, let's say, anatomy. If you talk about a patient with appendicitis, why do they have referred pain, etc. So they have clinical concepts and then take through cuts through the whole topic. They take big topics like chest pain. What could chest pain mean, etc. There's also now some, and that they try to have that as interactive as possible in smaller groups. We have our total year will be about 240 students, and we have split them up in 2 half years, so 120 per half year, and they rotate through different things. And in the groups, we try to sit with 20, 30, ideally would be smaller. That would clearly need more clinical academics, which is very hard to get. So we may have a paper patient, we may have a specific question that they need to address. When they go into more clinical years, we push them to go to PubMed, etc., and look at the RCTs. Yeah, and then so that's and so gradually, of course, throughout the years, the focus goes more. You move away from the basic topics into the clinical topics, like the big specialties. Yeah, we have now, and that's with the new location, we have now on the main boulevard in Adelaide, we have now our main research institute, the South Australian Health and Medical Research, summary, together with our largest hospital in Adelaide, that's a Royal Adelaide Hospital, which has no maternity, so I don't often go there, and a uni. So altogether, it's like a big health education site. Yeah, so as I mentioned, we're now in this Doctor of Medicine, which we say that's equivalent to a master's degree. So they have, and we really put more science there. I think we had dropped the standards a little bit. We got a bit more, let's say, a bit too relaxed on the end product, the young doctor. I think we tightened the standards, and that happened everywhere. And also, we do think that they also need to have proper skills to go into literature and at least read any paper with critical eyes. So we have a lot of journal clubs where, and that's per different specialty, of course. So surgery, internal medicine, ONG. Lots of journal clubs where the students have to get one of the big manuscripts, read it, criticize it, and that's important part of their education. So I already mentioned, so we have, it's a standalone medical school. We have 5 training hospitals. I'm in the Northern Adelaide Local Health Network, the Lal McCune, which is a very, very poor area of, so we see a lot of poverty, also in a wealthy country like Australia. And doctors like to come to our hospital because there's a lot of problems with poverty, poor nutrition, drug use, which major mental health issues, which are a big part of healthcare, public healthcare now. Yeah. And of course, so if you look at the clinical years, which is if you count from baseline, so they had the bachelor at year 3. So year 4 is then general medicine, internal medicine, surgery, mental health, musculoskeletal, cancer, and palliative care. Year 5 is where I spend most of my time, because that has pediatrics, obstetrics, gynecology, GP, anesthesia, and the students have to do rotation in with our indigenous patients. You may be well aware that we still have substantial percentage of indigenous patients, and their healthcare standards are actually lower than in Bangladesh, to give you an idea. Yeah, so I think we almost have 2 different populations where there's Western healthcare setting for people living in the cities, including indigenous people, but the people that live in the remote areas, they have very poor outcomes, and all the young doctors have to go there to do a part of rotations in the hope that some of them will stay and work in these areas. Year 5 is then the last training before they become an intern. And again, I'll come back to intern. Then they have to do surgery, internal medicine, psychiatry, and emergency medicine. And as I have here, they also can then develop a bit of a profile. Mostly by then, they do know a little bit what their direction is. So they can say, I do an extra 6 to 8 weeks in surgery, or I do an elective in obstetric gynecology, or I go back to indigenous patients. And we strongly encourage them, and we facilitate time there. And that's, of course, very much where I have my interest with Surabaya. So now post-COVID, actually next year, there will be one of Adelaide's students coming to Surabaya. And hopefully, together with Professor Afzal now, we can start a program where we also get last year students from Surabaya, for instance, coming to Adelaide, because I think it should be, we can both learn from the experience in another setting. They can also do a more sophisticated research project, particularly if they want to see research as their future career. Now, so basically, and that's also an important difference with the system in Indonesia, when they finish, they have provisional registration. Then they have 12 months as an intern. And as an intern means that they are truly working in the hospital. In contrast to Indonesia, they start to get a salary from then on. They have a quite, it's not high, but they have an acceptable salary. And they have to do surgery and medicine, as that's mandated, but 2 rotations, they do 4 rotations in total. 2 big rotations are up to their choice. And they typically then choose for the direction that they want to go. If a person wants to become a GP, they do 2 rotations with a GP. I think that's very individual. But it's important, our last exam is in year 5. So in year 6, there's no further exam. Then you just need, at the end of your rotation, your supervisor needs to be happy with your performance and your knowledge. And only then you are a doctor, then you are qualified to be, then you're a registered doctor and you're allowed to work in Australia and New Zealand. The university is not involved with placing the interns. So the university brings them to the MD, the medical doctor. Interns is a job. Although still training, you'll get a salary, and that's between you and the hospital. After the intern, you become a registered medical officer, an RMO, at least for a year. And then you start to do, and at that stage then you have to make a choice. Do you become GP? And that's 3 years of GP. Do you want to be any of the major specialties? That could be psychiatry, surgery, ONG. I think the only 4 year, I think dermatology is still 4 year. I'm not sure about ENT, but all the big specialties are 6 years then. And we call them registrars here, but that's equivalent to residents. But they get, in contrast to Indonesia again, they have to work hard. They often work easily 70 hours per week, but they get a proper salary. But that's completely detached from the university. Usually university is nothing. The university brings them to MD and then it stops. Then you become a hospital employee. Some last slides. I found a slide. Yeah, that's your old medical school, which is lovely. Just a role in the clinical academic, and just to highlight that. So the teaching in the hospitals is done by all consultants, also the consultants that are not involved, that don't have a university that position. I have, so the clinical academic like me, I have a hospital job and a university job, and that's called a clinical academic. There's many consultants that are only hospital, and then I need to, it's my role then to encourage them to do teaching, and they typically, I'd ask them to do teaching on their favorite topic because they feel more at ease with it. So if we have, again, I'm a obstetrician gynecologist, so I know who is the cancer person, who's the person who's doing the prolapse surgery. So they're all allowed to talk about their favorite topic. So that's the stress is a bit less. While of course, as clinical academic, we need to get the overview over the overall teaching and need to encourage research. I'm a firm believer that research and education go very well together. I know that some of my colleagues say, oh, I can only do education or only research. I disagree with that. And I always try to basically in my approach to teaching, I probably are closely more aligned with people like Socrates, the old Greek philosopher, where I do know that by the time I see them in year 5, there's a lot of knowledge in their brain, but they often don't connect the points. So, for instance, if I give you an example, let's talk about blood pressure, so I talk about Korotkov sounds. And this is the question that I asked recently, 2 weeks ago when I was in Surabaya. Say, how do you correctly measure blood pressure? Very simple concepts. And I let them sweat and struggle. And I normally play them to make it interactive. I play the pregnant patients and say, okay, I'm flat on my back. How do you measure my blood pressure? Can I be flat on my back, etc.? Or can I be on my side? Just for them to know, because they all know, they have learned that if you measure blood pressure, the cuff should be at the level of your heart. But by the time they get in the hospital, they often forgot about that point, or they just, what I often see as clinical academics, that they don't connect the different points in their thinking while they actually have the knowledge. And also an example that I just had, for instance, here, I used this in Surabaya when I was there 2 weeks ago, just this is just to get them thinking. And we say, okay, we do small for gestational age baby, which is per definition under the 10th centile. So now I say, what's the rate? Of course, it's just 10%, but to make them, to make the knowledge more operational. And that's typically, I think that's where I think the experience of the clinical academic comes in, because over many, many, many years, you know where their problems in the thought pattern is. I would not expect that level of insight in where the weaknesses are of medical students from the non-academic, basically the consultants. Now that's just a bit of statistics, and I explain them that's just statistics, of course. Then to finish off, and then we can go with the Q&A. Big thing is student assessment, of course. Now we still do that quite the old-fashioned way. And I'll come back to that in a moment. We use the oral structured clinical examination, the OSCE. I don't know if the same instrument is where you have standard cubicles with a real patient or fake patient that has to play a role. They have to write an essay, there's an MCQ, and they have their research project. One of my close friends here in Adelaide is Professor Lambert Schuerts. He works for Flinders, and he's like one of the international gurus on student assessment. And as you may be aware, there's a lot of, and I agree with him, there's a lot of criticism on the way we do exams nowadays. Because you take one cut on one moment in time, but that is, if you would do that same student another time, on another day, it is actually not that reproducible. So there are clearly the people in this field, and it's not my field of expertise, people like him are doing it. They're looking at now, they're using blockchain technology, so that's the underpinning thing with cryptocurrency, where student over the year builds up a portfolio of things that they have done. Could be an essay, they could have been doing a literature study, they could have done a presentation, they have presented some patients with a differential diagnosis using PowerPoint, and all these elements are then captured using blockchain technology. So you can see at some stage, this is what a student has successfully completed. And if I listen to these experts, they say in a few years, the standard student exam as we currently know it will be just gone. But we're not there yet ourselves, but it's rapidly moving. Professor Schuerts, my friend, works now, for instance, with big groups in Singapore and in Taiwan, where they're rapidly going towards and that young colleagues make their own portfolio, so that, and it will require mentoring. So probably one academic looking after 10, 15 students, and they can see them grow and learn and mature. And at some stage after 5, 6 years, you can confidently say this person is ready to become a doctor. So that's a bit of my slides as an introduction. I will take this off and then we should be, yeah, back to screen. Okay. So that's a bit of my introduction.
Yeah, okay. Thank you, Prof. Dekker. And before we move to the question and answer session, I would like to again just introduce you, because maybe the audience don't know that who are you, Prof. Dekker.
Oh, sorry.
But you are our friend. You are a visiting professor now, yes? Visiting, yeah. Professor Dekker is currently the academic head of Department of OBGY, Northern Adelaide. And also, Prof. Dekker is one of our visiting professor. Yeah, yeah. Maybe you can just read it, colleagues and friends. Okay.
Yeah. So just while you're reading, some I have a Dutch training.
Yeah. Yes. You can just.
Yeah, I did my
go
PhD.
On your CV.
Yeah. You see the photos a few years old. I have less hair than on the photo.
It is only one PPT or maybe more than one, the slides?
Sorry?
You have only one slide or more than one?
No, there's only one slide on myself. Yeah, no, there's only one.
Yeah.
So I think I came to Adelaide in '98.
Yeah, okay.
And then I've been coming to Surabaya since I did check it with Professor Eri Gumilar. The first time I arrived there was 2001. So I've been coming to Surabaya now for 21 years. I think I probably have been there now. I can't remember anymore. I think it's probably 50 or 60 times now. Yeah.
Okay. That's all, Prof. Dekker?
Yeah, on my personal introduction. Yeah,
Okay.
there's nothing.
So,
there's nothing
but the important thing that you are one of our visiting professor. Fakultas Kedokteran Universitas Airlangga in Indonesia. Yeah. Okay, friends and colleagues, if you have a question, you can just raise your hand or just say that I would like to ask something to Prof. Dekker, please. Is there any question?
May I ask, ma'am?
Please, just say, yes, Dr. Nurul, yes?
Thanks a lot, Prof. Rita. Hello, good afternoon, Prof.
Good afternoon.
Yes. According to your explanation, I'm interested to know the technical activity, the technical teaching learning over there on the clinical rotation. We call it clinical rotation here in Indonesia. It is a custom here sometimes that our students are taught by resident student, sometimes in some activities receiving patients. How about in Adelaide? Whether it is possible for students also be taught by residential students, specialist program. Thanks a lot.
Yeah, so this is a very good question. So the medical student, and when we look at our specialty residents, they are definitely supposed to, so when, let's say if I, for instance, take an antenatal clinic that I run, and also the residents, they're doing that often then together with the students. Also the residents are doing this, do it with the students, and they help them to do the first palpation of the baby, correct blood pressure measurements. And that's similar in the, if you look at the emergency department, if the patient is not too sick, the emergency doctor residents will allow the students to first observe the patient, make a provisional diagnosis. Yeah, so the residents are involved in that. Basically, we call that teaching on the go. You're just in your flow of your clinical practice, and the residents are definitely involved, and clearly they're getting better when they get to their more senior years. The first year residents are so overwhelmed with their own, to make sure that they do well, that I think we tend to roster our students with the more senior residents. And I mentioned we go from intern, resident medical officer, and then you become resident. Here it's called registrar. Only the registrars are doing medical student teaching on the go. So to say, the interns and the resident medical officer, they are not involved because they're just too junior to do teaching. That's a very important question, and it's often, particularly for the weaker registrars, they often find it difficult to be efficient enough with their time to do medical student teaching. That's a fair point. Yeah.
Yeah. May I continue, Prof?
Yeah, of course.
Yes. Is there any formal rules or regulation that we should pay attention, particularly on the teaching learning activities among them. I mean that the residents student are also students, right?
Yeah, the residents, you talk about the special residents, so the specialty trainee.
Yeah, I mean.
Yeah, they are students, but they, of course they had their 6-year medical training. Then they are intern RMO. By the time they see students, they already have been working in the direction for 8-9 years. So it's a different. They have enough knowledge to be able to supervise medical students in very baseline things. Yeah, so I think that's, but indeed, and it's not uncommon. I did a busy clinic this morning where the registrar, the trainee registrar, came in with the student. Said, listen, the student had a question, and I actually don't know the answer, and that's fine. Then you teach two people at the same time, and that's fine. That's your role as consultant. But you're right. But you have to realize that in Australia, after their 6 years, they do get a salary, a proper salary, and the hospital expects them to work. And part of their work in the teaching hospital is to do a small part of their time to medical student teaching. To give you an idea, as clinical academic, in my dual role, I have about 50-50. So 50% of my time is clinical work, 50% is university.
Thanks a lot.
Okay.
Thank you.
Thank you, Dr. Nurul. And I also add Dr. Nurul question, Prof. Dekker. Do you think the resident need a special course to be a teacher for their peer? I mean, some course to be a teacher.
Yeah, I hear your point. In ideal world, Professor Rita, I would agree with you. If we have senior registrars that clearly want to have an academic career, and they will tell us, listen, I want to be a clinical academic, we will facilitate for them to do a further teaching course, which will probably take them about half a year. But for practical reasons, we cannot ask that from all our residents. So I think if it's simple teaching on the go, in seeing patients, I'm okay with that. If by the time they want to do more proper group teaching, bigger topics, I would agree with you. Definitely need to have a course in their own teaching skills. Yeah, I agree.
Okay, thank you. And now we move to the next question. I think Dr. Surya, Surya, you raise your hand. Dr. Adi,
yes,
please.
Thank you, Prof. Rita. Dear Prof. Dekker, do you mind I cannot put on my video? Because...
No, but I can hear you. I can hear you. That's good.
Okay. Thank you so much. I want to ask maybe 3 short questions. First of all is, what kind of small group discussion is the form in your university or school? Is it problem-based? Is it a flipped classroom? Or is it team-based?
We do, when they do in their, I'm talking about the clinical years now. In their clinical years, we just finished a group. That's the second group of this year's. I have basically about 10 students, and that's problem-based learning. So they know broadly the topic, So I mean, I might say, being an obstetrician, I say next week we're going to talk about, let's say, vaginal birth after cesarean section, and then they're supposed to read about the topic, dive in the literature, and then when I see them on that afternoon, I typically have sessions of about 2 hours with about 10 students. We have then 2 hours where I have 1 or 2 patients that they may have seen on the ward, and they have to present the patients. And then we go into a discussion on the different aspects on how to manage the issues of that patient. And that will be typical group size. We ideally will be 8. We definitely want to keep it smaller than 12. And that is affected, and I shortly mentioned it, but it's actually very hard now to get clinical academics in Australia. That is a huge issue, and that particularly in our specialty, because I'm one of the last, as we say, last of the Mohicans. We have a few male consultants left. The rest are all women. We have 24 training doctors. One of them is a man. 23 women. And if I look at my own lovely daughter, who is now 39, she's in intensive care specialist almost. Lengthy training, 2 children. Her husband is the architect. So as an example, in this case, my own daughter, these very good colleagues, they go through their career and they say, okay, I have my family, I have my career, and there's then no time left. And that's a choice to do research and teaching. So it's very, very hard now to get clinical academics into our specialty. More male-dominated specialties like orthopedic surgery, as an example, they probably have less of an issue, although there's a very strong private sector, and they do know that in private they can earn 10 times more. So there's other challenges. But to give an example, I'm now very hard working to get a new clinical academic recruited from Pittsburgh in the United States. I cannot find a clinical academic here in Adelaide now who's willing to do basically, because I'm almost 67, so I need to be thinking of slowing down, who can basically take over my position, which is frustrating. So I think, and if we would have enough clinical academics, we will probably do group session. Coming back to your question, we will probably do groups of about 8, but we have to compromise.
Okay. What about, you mentioned about that is the small group for later years when you are when the students are with you. What about the first and second year when they have a lot of basic science? What kind of small group?
Yeah. I think I must say I've never for a long time I've not been sitting in one of the first years to see what the experience is. They run with bigger groups, and they so it's less problem, not like direct interactive problem based. They do get a topic, and they try to make it either scenario based or problem based. And as I mentioned in the beginning of my slide series, they try to go from basic big symptoms like you have fever. How is it possible that you have fever? You have chest pain, and then look at the anatomy, physiology. So they do have, for instance, For chest pain, I do know that they work with, there is a professor of anatomy, a professor of physiology, there might be a critical care doctor, and together then they look at a paper base of a patient that, let's say, presents with chest pain.
Yes.
And they try to make it as interactive as possible, but they mostly looking at groups of about something like 20 students, which if you then have a student that doesn't want to be actively involved, you can easily miss that student, and that's reality. Yep.
Yeah.
Dr. Adri, please
Yeah.
louder. We can hear your
Okay.
voice.
Sorry. Another question is, you said after 5th year, then they have an exam,
Yeah.
and then there is no exam in the 6th year.
Correct.
So when they already 6 years, they finish, do they get like a certificate because there is no exit exam?
Yeah, because there's no formal exam anymore, but all rotations they have, we treat them as year 6. They're almost becoming an intern. So the year 6 students would clearly be challenged as a future intern, giving actual patients to manage, supervised management, but you have then close interaction. So I have, in a whole year, I have 8 year 6 students that directly report to me. And I have several other colleagues are also willing to take that year 6 load. And they really then have to manage the patients, dictate discharge letters, make a script for medication, which then I have to sign, of course, because they're not a licensed doctor yet. And they have to report back to me. So you get a proper, these 8 students that I see throughout the year, I get a proper insight whether or not they are ready to be signed off for their year 6. So it's actually, it comes back to what I mentioned, what the future is of exams. Actually, that year 6 makes me much more confident that by the time that I have seen a student over a period of 8 weeks, it's our 8 weeks rotations, that I know, okay, this student is good. And if there are real problems, which is relatively rare, most of the issues that we do see are mental health issues with the students. They're young people, they have their stresses, they might have marital issues or whatever. So there's often the problems that we do see, they're rare, but have to do with their mental health issues, etc. Most of the students perform quite well at that stage of their career. Yeah. Otherwise, the system would have filtered them out. The year 5 exams are pretty strict. The OSCE exam, the multiple choice, it's a failure rate in year 5 is basically set up. We basically expect about a 25% failure rate.
Wow.
in year 5.
Wow. Okay.
And then they have to have the opportunity to do it again.
Yeah.
In that same year, and then about another. In the end, we get to something like 90% get through.
Yeah.
And then 10%, either they are poor on everything, and then they have a chat with probably the dean.
Yeah.
And say, listen, there is an issue here, and some of them will drop the study. There might be a drug problem or mental health problem. Some of them decide, okay, I'll do a complete year again. So they repeat the whole year 5. So the year 5 is the big filter.
Yeah.
In year 6, we see them as a soon-to-be doctor. Can they act like a doctor? How do they interact with the patients? How do they interact with the nurses? Can they build up a doctor-patient type of relationship? And that's actually costs a lot of mentoring time. Yeah.
If I may, one more question.
No,
Okay.
too long, Dr.
Yes.
Adri, because
Sorry. Yes.
the time is Dr. Fitri just got under.
Okay. Thank you. Thank you.
After that, if the other participant no question, then you can just add one more question.
Okay.
Maybe, dear colleagues and friends, is there any question for Prof. Dekker? Dr. Helmia?
Yes, Profita. Thank you.
Okay.
very much.
Please, if you
Hello,
add
Dr.
question.
Helmian.
Good afternoon, Prof. Dekker.
Hello, Dr. Helmian.
Very happy to meet you. Obviously, I would like to thank you about your information related to course for the residents as a teacher. I think I will follow your way. You know that we.
So I missed that last bit, what you said.
Okay.
Louder, please, Dr. Helmia, your mic, you have to make it
Clear. Thank you. I would like to thank Prof. Dekker related to your information about the course for the residents as a teacher for the students. This is so helpful information, and I think we are on, and I will follow this your way to make a course for the student as a teacher for the student. Thank you very much for this motivation and information. Secondly, this is about clinical rotation. We know that this is a very busy environment for the students and for the clinical academic teacher for the teacher like us. In my department, I come from pulmonology department, parts of internal medicine in Surabaya.
So that's a pharmacology?
Pulmonology.
Yeah.
Pulmonology, yes. In my department, we allow the students to meet the patients in clinical rotation. And then after that, we make a discussion with one supervisor. So it is about 7 up to 10 students. This is the most strategy for the student to achieve the competency in patient management, like that. But you know, our obsession is that all of the students will be able to manage the patient, but this is our obsession. The reality is not all of the students can pass the test in the final rotation. This is the most strategy. Do you have any other strategy to help the student to achieve the competency in patient management? I think this is our.
That's a short question, but that's of course the big crux. I think if I can divert a little bit, I mentioned this, my personal friend Lambert Schwartz, who is he's like a medical education expert. He's not a doctor. Yeah, he's originally a doctor, but he's completely already, his whole career is medical education. He said we're doing it the all wrong way around. He said because now an exam feels like if you've not done it right, it's like you almost get a penalty. You have not done it right, and they say no, it's different. Their approach is you're sitting here in the university, so you're already, because you have been accepted in university, you must be an intelligent young person. so it becomes very much like a team effort to say, okay, we can see from any assessment that you struggle with this and this. Let's sit together, and that requires close mentoring, and then the mentor and the student try to analyze where is their problem, what is the bottleneck, and they really take a long time, and the students, that happens at Flinders University now, which is quite advanced in their medical education. They really dig down then to understand where is the problem of the student, because they all are smart young people. Was there, and sometimes the education model was not good for the students. There are other things that block their study, and you have to analyze. It might be the teaching method was not good, and some students are clearly better off with old-fashioned passive teaching, like this is the knowledge, you learn this and I'll see you tomorrow, things like that. But it's different from student to students. And they spend a lot of time in a very much a team effort to saying, we have a problem because we can see that you're not making your milestones. Can we sit down with you and try to discover where your blocks are? And sometimes it turns out that that student has missed a few critical lectures in earlier years, or just might missed another point in their knowledge. And I think that's as a general approach, instead of saying almost like you're a faulty student, you failed, saying no, we are with you, we are there to help you. Let's sit down with you and try to understand where the problem is. Now we are in Adelaide Uni, we're not there yet. We're working towards that. We still have a what we say like basically a punitive system where you say, oh, you did not make your exam, almost like you're naughty, which is nonsense, of course, because the great majority has really tried. Occasionally you find, of course, it's like a Gaussian curve. You have a couple of students that are just lazy, and you have, and typically I would think that you see that they're poorly performing on many specialties. So I think the really bad students, you filter them out. It is that middle group that is basically okay, and then they sometimes don't make the mark. And then it's our task as university, in my opinion, I agree with Professor Schwartz, that we should sit down with them and try to analyze what their obstacle is. And then often that then translates in extra personalized training modules. It might be issues with statistics, pharmacology, or whatever. I think that's, and they're very good results. But it's a smaller university with good staffing levels, and they have the funding to do small group mentoring, which we cannot do at the moment. I would love to do it, but we cannot do it.
Thank you very much. So the problem is not comes from the students only, but the teacher too, I think.
Yeah.
We have to improve that.
Yeah.
Yes, thank you, Professor Dekker.
Yeah.
Thank you.
And I think I've done a lot of teaching over the years, and I do know, and it might be because of my Dutch accent in my English, or I'm very passionate about my topics that I teach, that I might not be good enough to simplify sometimes difficult concepts, or occasionally when I get criticism, what definitely happens, then I clearly missed the fact that some students, their basic knowledge is still not just enough to make that step in a complex topic, which means that I have to start simpler. So I certainly, so we get, and I did not have mentioned that before, we get the CELT score, that student assessment education score. So all the students score us as well. So we all get, as clinical academics, we get 4 times per year for the 4 groups that we do of year 5, where, because I work in year 5, we are assessed by our students and to see if can they approach us, are we friendly, are we enthusiastic about our teaching, do we make it interesting, are we engaging? So the students have to score us. And if you have a poor score, then you actually have to go to the medical education department as the academic, and they sit down with you and say, listen, you have to work on this. And if that's a permanent problem, that might be a risk for your job. Yeah, so I think that's yeah.
Okay.
So I'm actually, when I get my CELT score, I'm always very interested to see how did I perform as an educator. Yeah.
Okay. Prof. Dekker, I like to add Dr. Helmi's question about how to research. You do the research about ourselves from the questionnaire to the student. Actually, here in Erlangga, we do it every year.
Yeah.
But you know, sometimes it is hard to get a negative evaluation from the student because Asian people is too polite.
I know.
To just their teacher.
Yeah.
So we never get something that true.
Yeah, I understand your problem.
But it is routinely the SPM, what do you call it? The head of the
quality assurance, Prof.
quality assurance do the survey. But overall, yes, you are right. We need that the student because they are our customer.
And it's
their hak, their right to just judge the gurus, the teacher.
Yeah.
Okay.
Yeah.
Thank you
Now,
for your.
Yeah, can I add to it? So we had that issue as well. And up to a few years ago, the response rate of the students was low. And then we made it now when they have their mid-year exam in the year 5. And I assume the other years do the same. I have to check that, but in year 5, which is the big year for assessment, after they finish the exam, they have to submit their assessment of the teachers. It's part of, they have to, and it's anonymous, so we can never know who the students are. Clearly, they have to identify the teachers, so they know, you know, if they were in your hospital or not. But the group is big enough, you don't know the individual student, and they sometimes can be very critical. They will never use, let's say, improper language. But they might. They clearly so they have to score, but they're also allowed to do some text if there's any serious problem, and they have to submit that as part of their so you have to probably say, listen, this is, you have to probably say, we need your feedback, and giving feedback is also important for you to give us feedback, and that should be mandated. You will have to do it. You do it on basic anonymous. And then students feel safe. If it's not anonymous, they will never say anything, of course. No.
Okay. Thank you. And now we move to the next question from Dr. Dea. Yes, Dr. Dea, please.
Yes.
Yeah, Dr. Dea. Hello.
Thank you. Hello, Prof. Thank you, Prof. Rita. Good afternoon, Prof. My name is Dea. I'm from Diponegoro University Public Health Department. One of the methods.
If you put your mask down.
Oh, okay. I'm sorry.
I can hear you a bit better.
Is it more clearly now?
Yeah.
I'm sorry, sorry, sir. Well, one of our assessment to the student, I'm from Department of Public Health, is we use portfolio assessment. But there are a lot of problems that the student usually do not take the portfolio seriously. Do you have any trick or what your experience in Adelaide to
So you see,
overcome problem?
so you use the portfolio. They have to build their
Yes,
portfolio.
Yes, we are using portfolio.
Yeah, I think I mentioned that we are working towards that. We're not there yet, so you're ahead there. That's very good. I do know from Flinders, where they do use this, that if that students really realize that portfolio is the main part of the assessment. So if they don't submit the thing that they've done, either group of patients or a critical topic in primary health, they will not get through. So you have to make it clear that this is the portfolio is the main tool that you use for assessing their progress in a good team spirit. I think that so that you need to say them, if you put emphasis on the portfolio, that you highlight that you're very modern, that students are not perhaps doing a formal standard exam anymore, but the portfolio is your main tool to assess them. And I think it's, but you're more advanced. We are working towards that, but you're doing it already, which is great. Yeah.
Yes. Thank you, sir.
Okay. Hope you are satisfied, Dr. Dea.
Terima
Salam
kasih, Prof.
untuk
Rita.
Samarang.
Oke, Prof. Rita.
Okay, we move to the next question from Surabaya Arin, University of Surabaya. You raise your hand. Arinda. Please, Dr. Arinda.
Yes. Okay. Good afternoon, Prof.
Hello, Dr. Arinda.
Yes, I apologize for a little out of point. My name is Arin, and now I work as an laboratory technologist.
You work as a reproductive technologist?
Medical technologist.
Medical technologist, okay.
Yes. Okay, I want to ask you, Prof, if I want to study medicine there, like from the beginning of the medical education, are there special rules for this condition, Prof? Because I have an associate of medical technologist. According to your presentation, I only got about how to apply from high school to get there. Thank you, sir.
So sorry, the line is not very good, but if I listen to your question, you are interested in getting into medicine, and in medicine into Australia, you mean?
Yes, sir.
Yeah, so that would mean for any Indonesian student would mean that they have to basically show their that they've completed high school. Now that's not difficult, of course. If they have a other professional degree like you have, and if that would be assessed to see if that would be seen at a bachelor level, whether or not that would be suitable to go just to the clinical years. But if not, you have to pass there's an entry exam for overseas doctors. No, not doctors. That's overseas. That's individuals that want to enter the medical study, and there is. Try to think of the name. The name escapes me now, but different universities have their relatively strict entry exam that people have to pass, and that tends to have a focus on things like biochemistry, knowledge of, and this is high school level biochemistry, and think I like interesting human behavior and physiology, etc. If you say, listen, I only did the arts, not that I'm against arts, but that will probably not help you to get into medicine. So I think generally speaking, it is probably easier for Indonesian people that want to work in Australia to complete their Indonesian medical degree and then just do the AMC exam here in Australia, because that is it's a real exam, but it's not. It is a realistic exam. It's not, the bar is not set too high. If you look at the United States, the exam is really set up to keep you out. But we do need doctors in Australia. We get a lot of doctors from India, lots of them, and they typically come in with their Indian medical degree, sit the exam here, and continue with being with a resident training in Australia. If you, I don't know what for a medical technologist, that's in imaging that you do. You work in radiology, or Dr. Arinda, do you work in radiology, or what? What's your? I think we lost Dr. Arinda.
Yeah, I think it is the internet problem because yes.
But that was a very, with all due respect, that was a very individual question for her scenario, which is different from the broader topic of medical education. Yeah.
Okay.
Yeah.
I'm sorry, sir.
Okay. Arinda?
Because of the connection.
Yeah. Okay.
I in general laboratory, like hematology, everything.
Yeah.
Okay.
Now, if you feel, because I don't have insight in all the courses that you have done, you have to see if that would fit with a bachelor's degree. If that finishes off with accredited bachelor's degree, you could try to get in one of the postgraduate, university courses, which most other universities give, and Adelaide Uni does it now as well. And you say, I have this bachelor degree that's been assessed, and the university will see if it fits for you to do your clinical years of medicine then in Australia as a student. Very much depends on your initial training. Yeah.
It is clear for you, Miss Dr. Arinda?
Yes, ma'am, I take the point. Thank you. Thank you, Prof.
Thank you. I have a question in the chat room. Dr. Devi, you still here, Dr. Devi?
Yes, Profita.
So you can just ask by yourself.
Okay, thank you, Profita. Good afternoon, Prof. Dekker.
Good afternoon.
I'm Dewi.
Good afternoon.
I'm lecturer in Department of Anatomy, Histology, and Pharmacology, Faculty of Medicine, Universitas Erlangga. I want to ask you about the psychological problem that faced by the medical student. As we know that the medical student is highly risk population to experience mental illness. Is there any facilities which provided by your faculty to support their psychological problem, and how these facilities are known and accessed by the student?
So I missed because the line is not ideal. So this, you talk about the health of the student, their mental health, or their, what type of health?
I talk about the psychological support by your
psychological
faculty.
Support. Yeah.
Yes.
Yeah. We do have a formal psychology support for the medical students, particularly around the COVID time. That was totally overloaded with very stressed students that felt that they missed a complete year. But in normal years, students can just totally independent contact the psychologist support, and that might be anything. That might be, let's say, issues with their relationship, drugs, which is unfortunately a problem in Australia. It might be that they feel stressed by the study because they have to earn money because to pay for the study and their parents are not supportive. So different things there that may, or it might be that as a mentor, we have seen that a student is not performing well. And in our conversation with the students, it's clearly that they're mentally struggling. That they're mentally struggling, and then we encourage them to seek contact with the university psychologist. I think there are, so we have a total, let me think, we have 6 years. So we have about 1,500 students in the whole medical school. As far as I'm aware, we have 3 full-time psychologists for these 1,500 students. So I never checked it with them, but I think they will be quite busy. Occasionally, this is a student that was the most recent case that I was involved with was a student that was involved with the patient care of a mother that died. Now, maternal death is very rare here in Australia, so that was certainly hugely traumatic to that student. And then in that case, the university psychologist helped to counsel that student, in addition to the hospital counseling that she got. Yeah.
It is okay, Dr. Dewi?
Okay, Prof. Rita, thank you very much for your explanation, Prof. Dekker.
Okay, Dr. Dewi.
Okay. Dr. Fitri, this is maybe 2-3 minutes before for 3:30. But I take my right as a moderator and also a participant as well. So I will ask you, Prof. Dekker. It is about the percentage of lecturing student. How many percentage, I mean 50%, 60%, that you just, it is ideal to give the student lecturing them in the classroom, or let them learn by themselves, independent learning? Because we in
I get your question. I get your question, Jen. Yeah,
because
that's a very
in Faculty of Medicine Atlanta University, I think we have so many times just use for the lecturing the student. But when I asked in some, I met a professor from German, and he mentioned, oh, Rita, in Western people, it is too many independent. They just let the student learn by themselves. Which one do you think that's the good way to learn and how is it in Australia?
Yeah, that's a that's a very important question, Professor Rita, and a difficult one. If you just think of a bit of a Gaussian curve type on the student capacity, you will probably have 20% of the students that could be basically going with almost no supervision. They're just the smart people. They will find their knowledge, they go on the internet, read the textbook, find the journals, and you only have to see them then now and then, and they could be ideally building their portfolio and they show it. Then a big bulk of students, I would say about 60%, do need some form of directed, you need to guide them. Yeah, and I think there's nothing against that. It's just a different mindset. Some of the very good doctors do need some guidance in their learning. As I mentioned, and I illustrated in my slides, often I see that students have these isolated bulbs of knowledge, and they don't know how to connect them. And I think that's where our role is. So they can dig themselves into a PubMed search and read on one area, but then they don't connect it, they don't translate it to that other part. So I do think a big bulk of students do need that insight and expertise of a enthusiastic mentor. I think it's, in my opinion, would be minority, 20-25%, that you can just say, go by yourself and we assess you 4 times per year. And they're the high flyers, and they will do everything well. They almost don't need us. But I think it's a minority. And I think I mentioned that I have a Dutch background, and also the Dutch people can be, in the Hollands it's called eigenwijs, is the Dutch word, is basically they think that they know better. It's very Dutch thing.
Yeah, very Dutch.
Very Dutch thing. I'm very well aware of that. My wife still reminds me of that.
Oh, yeah.
I see Dr. Anna there, so she knows about that. But anyway, I think in some stage in the Netherlands, we had the same feeling that, oh, the students have to find their knowledge, and we made the rules of mentoring supervision too loose, with some very bad outcomes. We were then too late in identifying students that were not performing, poorly performing. We did not have the insight of where their thinking was. As I mentioned, my predecessor here, Professor Jeffrey Robinson, was very much thinking like students should find the knowledge, a very pure model. And as I mentioned in my many discussions before he died, he started to agree that there was a big sizable group of students where they need to be a bit more guided. So I think that's, but it's a key question that you asked there, how because all the knowledge is on the internet. They can find everything nowadays.
Yes.
But they also get lost. They also get lost in the knowledge. So I think that for the very smart people, they do it. They do it, of course they do it. But by definition, we're not all at the end spectrum of being like an academic type of, maybe type of intellectual. That's reality.
Yeah. I think they need to make a meaning of the journal that they find in the, not just memorizing.
Yeah,
but
because in the beginning they can also not. I think they have difficulty if they see lots of factual points without the overall perspective of experience. They cannot value the relative importance. I think it needs that mentorship, and it might be because I'm getting a bit older, but I hope that there is still value in talking to and closely mentoring, and we need to have more that team approach with the students, that we say, listen, we can help you to become a better doctor because we do have 20, 30, 40 years of experience.
Okay.
And the internet cannot teach you experience.
You're right.
Yeah?
Okay, thank you very much, Professor Dekker. And I think we come to the end of this session. I give back to Dr. Fitri. Fitri, thank you.
Okay.
And now this time is yours.
Thank you, Prof. Rita. Thank you, Prof. Rita, for guiding this webinar. And thank you very much, Prof. Dekker, for sharing and a thoughtful insight, particularly in teaching medical students and the best practice that have been carried out Okay, I think this is the end of this webinar. And on behalf of the committee, we would like to say thank you for joining us today for all the participants. Okay, and mohon izin, I would like to stay in bahasa, Prof. Dekker. Oke, mohon izin untuk mengingatkan para partisipan sekalian bahwa tes didik ini akan diselenggarakan secara rutin ya, setiap hari Selasa ya, pada minggu kedua, sehingga kami semoga bisa berjumpa kembali. Ya, see you again at the next webinar with a different topics, with different speaker. And okay, thank you for everyone. See you again, Prof. Dekker.
Thank you.
Prof.
I enjoyed very much. I enjoyed the Q&A, and good luck with the important topic of medical education. Thank you.
Thank you.
Thank you, Prof.
Bye.
Bye-bye.
Until we meet again, Prof. Dekker.
Till we meet again. Bye-bye.
Bye.